Hello and welcome to the topic Alcohol Use Disorder in the Psychiatry module. By the end of this session, you should be able to define alcohol abuse and dependence, discuss the pathophysiology and cause of alcohol abuse and dependence, describe the clinical manifestations of alcohol abuse and dependence, discuss the management approach to alcohol abuse and dependence, and explain the complications of alcohol abuse and dependence. Let's get started. Alcohol abuse or alcohol use disorder is a medical condition in which a person continues to consume alcohol despite the adverse consequences. Alcohol dependence is a previous psychiatric diagnosis in which an individual is physically or psychologically dependent upon alcohol, also chemically known as ethanol. Alcohol abuse encompasses a spectrum of unhealthy alcohol drinking behaviors ranging from binge drinking to alcohol dependence, in extreme cases resulting in health problems for individuals and large-scale social problems such as alcohol-related crimes. Alcohol dependence is a chronic medical condition that typically includes a current or past history of excessive drinking, a strong craving for alcohol, continued use despite repeated problems with drinking, and an inability to control alcohol consumption. There are some risk factors that may be linked to excessive drinking, and some specific genetic factors may make some people more likely to develop an addiction to alcohol and other substances. There may be a family history, such as family history of alcohol misuse. Genetic psychiatric disorders such as schizophrenia and bipolar are associated with alcoholism as well. The presence of both a serious, persistent mental illness and alcoholism is called dual diagnosis. Other than that, we could also consider other factors such as easy access. So there appears to be a correlation between easy access to alcohol, such as cheap prices, and alcohol abuse and alcohol-related deaths. Some stress hormones are linked to alcohol abuse. So if stress and anxiety levels are high, a person may consume alcohol in an attempt to blank out the upheaval. Those with low self-esteem who have alcohol readily available are more likely to consume too much. And people with depression may deliberately or unwittingly use alcohol as means of self-treatment. On the other hand, consuming too much alcohol may increase the risk of depression rather than reducing it. Let's take a look at the common signs and symptoms of alcohol abuse, which include wanting to stop drinking but not managing to do so, hiding the extent of the alcohol abuse in order to protect it, being in denial about the extent of the alcohol abuse problem, diverting energy from work, family, and social life in order to drink, becoming distressed at the prospect of not having access to alcohol, engaging in risky behaviors, slurred speech and poor coordination, impaired thinking and impaired memory, as well as poor decision making. How about the signs of chronic alcoholism? Here you would expect one to have gynecomastia, spider angiomata, Dupuytren's contractures, testicular atrophy, enlarged or shrunken liver, enlarged spleen, and parotid enlargement as well. How about other manifestations of chronic alcoholism? Well, in situations where there's portal hypertension, you may expect one to have gastrointestinal bleeding due to esophageal varices, hepatocellular carcinoma if it's secondary to a viral hepatitis, alcohol-related cirrhosis, having cardiomyopathy, as well as pancreatitis. The following are signs and symptoms of alcohol withdrawal. So here you'd expect one to have nausea and vomiting, diaphoresis, agitation and anxiety, headache, tremors, seizures, as well as visual and auditory hallucination. You may also want to take note of the signs and symptoms of withdrawal delirium, or also known as delirium tremens, which is an emergency. And these include tachycardia and hypertension, temperature elevation, and delirium. How about the signs and symptoms of alcoholism-related Wernicke's encephalopathy? These include ataxia, ophthalmoplegia, usually lateral gaze palsy, and confusion, which indicate Wernicke's encephalopathy. The signs and symptoms of alcohol-related Korsakoff syndrome include anterograde and retrograde amnesia, often with confabulation, and preceded by Wernicke's encephalopathy. So these will indicate Korsakoff syndrome. And how about the signs and symptoms of alcohol-related hepatic encephalopathy? Here you'd expect the person to have hepatic flaps or asterixis, and confusion suggesting hepatic encephalopathy. So what are the different severity levels of alcohol use disorder? Here the severity is determined by the number of symptoms present. For mild alcohol use disorder, there are 2 to 3 symptoms. For moderate, it will be 4 to 5 symptoms. And for severe, there would be more than 6 symptoms. So who is at risk of alcohol misuse? How much, how quickly, and how often a person uses alcohol will affect their risk of developing alcohol use disorder. Here are the list of some risk factors you may want to consider. Binge drinking, heavy drinking, starting to drink at a young age, a family history of misuse of alcohol, mental health conditions, and social and cultural influences. Alcohol consumption becomes a problem when it takes precedence over all other activities, and dependence can take several years to develop. So how is alcoholism diagnosed? The diagnosis of an alcohol problem is best made by comprehensive history, as well as using screening instruments for alcohol problems, which include the CAGE questionnaire. The CAGE questions should be given face-to-face, whereas audit can be given as a paper and pencil test. So the important 4 questions that make up the CAGE questionnaire include: have you ever felt the need to cut down on your drinking? So cut down being C. Have people annoyed you with criticizing your drinking? A. Annoyed. Have you ever felt bad or guilty about your drinking? G for guilty. And have you ever had a drink first thing in the morning to steady your nerves or to get rid of a hangover? Here being an eye opener. E for eye opener. Alcohol biomarkers are generally divided into indirect and direct biomarkers. Alcohol biomarkers are physiological indicators of alcohol exposure or ingestion and may reflect the presence of an alcohol use disorder. These biomarkers are not meant to be a substitute for a comprehensive history and physical exams by an appropriate health professional. Instead, alcohol biomarkers should be a complement to self-reported measures of drinking. Among the biomarkers that can be detected in toxic effects of alcohol would be aspartate aminotransferase or AST, alanine aminotransferase or ALT, gamma glutamyl transferase or GGT, mean corpuscular volume or MCV, as well as in certain places you may also be able to do the carbohydrate deficient transferrin or CDT. A blood alcohol level detects alcohol intake in the previous few hours and thus is not necessarily a good indicator of chronic excessive drinking. Blood alcohol levels are considered direct alcohol biomarkers. So blood alcohol levels that indicate alcoholism with a high degree of reliability are as follows, where it's more than 300 milligrams per deciliter in a patient who appears intoxicated but denies alcohol abuse, more than 150 milligrams per deciliter without gross evidence of intoxication, and more than 100 milligrams per deciliter upon routine examination. The Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, changed from differentiating alcohol abuse and alcohol dependence to a single category of alcohol use disorder, and the criteria are as follows. So it is a maladaptive pattern of substance use leading to clinically significant impairment or distress as manifested by 2 or more of the following occurring at any time in the same 12-month period. Alcohol is often taken in larger amounts or over a longer period than was intended. There is a persistent desire or unsuccessful efforts to cut down or control alcohol use. A great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. Craving or a strong desire or urge to use alcohol. Recurrent alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. Continued alcohol use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. And alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol. And how about alcohol tolerance? Alcohol tolerance, as defined by either of the following, which is a need for markedly increased amounts of alcohol to achieve intoxication, a markedly diminished effect, with continued use of the same amount of alcohol, and withdrawal as manifested by either of the following, where alcohol is taken to relieve or avoid withdrawal symptoms. Next, let's take a look at the complications of alcoholism manifest, which as follows: Wernicke's encephalopathy, characterized by ataxia, ophthalmoplegia, and confusion; Korsakoff syndrome, where there is anterograde and retrograde amnesia, often with confabulation and preceded by Wernicke's encephalopathy; and finally, hepatic encephalopathy, which is characterized by asterixis and confusion. So what is the first step in treatment of alcohol use disorder? The first step in treatment is brief intervention. Treatment for alcohol misuse, as well as following diagnosis, a healthcare professional will work with the person to determine the best course of treatment. Let's begin with stabilization. Many medical and surgical complications are associated with alcohol use disorder, but only stabilization of alcohol withdrawal and alcohol ketoacidosis will be discussed here. Here, when we discuss alcohol withdrawal, it's treated by oral or intravenous hydration along with medications that reverse the symptoms of alcohol withdrawal. The most common group of medications used to treat alcohol withdrawal symptoms is a sedative group also called benzodiazepines such as lorazepam, diazepam, and chlordiazepoxide or Librium. They can be given by intravenously, orally, or by an injection. Diazepam also comes as rectal suppository. Next would be detoxification. This stage involves stopping alcohol consumption. This is very difficult for an alcohol-dependent person, and it requires extreme discipline and usually requires extensive support. During detoxification, the medication is measured carefully to prevent physical withdrawal symptoms and is then gradually tapered off until no physical withdrawal symptoms are evident. Finally, we have rehabilitation. It's a short and long-term residential program that aims to help people who are most severely dependent on alcohol and develop skills not to drink, to build a recovery support system, and to work on ways to keep them from drinking again. To summarize, alcohol abuse and dependence, or also known as alcohol use disorder, we have defined it to be a continuous consumption of alcohol with physiological and psychological dependence on alcohol. We have looked at the risk factors, causes, and pathophysiology, as well as the signs and symptoms to look out for, specifically in alcohol abuse, chronic alcoholism, alcohol withdrawal, as well as alcohol withdrawal delirium, as this is one of the emergencies seen. Complications to look out for would include Wernicke's encephalopathy and Korsakoff syndrome in terms of psychiatric involvement, as well as the severity levels of alcohol abuse is categorized and shown in this presentation. So we have come to the end of this topic. Thank you.